In this part 2 module of pediatric pulmonology, we continue from where we had left in the previous segment. So let us begin with approach to wheezing in children. We know that wheezing is an expiratory sound which indicates partial obstruction in either the bronchus or its branches or the bronchioles. So whenever a child is coming to you with wheeze, from MCQ point of view, you should always look for whether it is unilateral wheeze or it is bilateral wheeze. If the question says it is unilateral wheeze and it is specially acute onset, you will always think of foreign body aspiration. What is foreign body aspiration? Aspiration means something moving into the airway. So foreign body aspiration will be considered. In case it is bilateral wheeze, you can have two broad possibilities. Either it is acute bronchiolitis, which is the acute infection and inflammation of the bronchioles, and second is acute exacerbation or acute attack of bronchial asthma. How would you distinguish between two? Both of them are having bilateral wheeze. When we say wheeze, we mean bilateral wheeze unless proven otherwise. Acute bronchiolitis will usually be a viral infection, whereas asthma is a atopic disorder. Bronchiolitis is seen in children less than 2 years of age, whereas asthma can occur at any age, but more common in older age group. Acute bronchiolitis shows no response to corticosteroids or short-acting beta agonists like salbutamol, whereas asthma shows good response to corticosteroids and short-acting beta agonists like salbutamol. So these are the distinguishing points which can help you in MCQ diagnosis of a child presenting to you with wheeze. You read a question, wheeze word is there, this is your approach to solve to reach the correct answer. Now let us discuss these individual diseases. Our focus will be on foreign body aspiration, bronchiolitis and bronchial asthma. First we come to foreign body aspiration. Foreign body aspiration can occur at any age. It can occur at any age, but it is more common in the age group of 6 months to 2 years. If you remember milestone, mouthing of objects begin around 4 to 5 months of age, and from there till around 2 to 3 years of age, foreign body aspiration is fairly common. What is the most common type of foreign body? The most common type of foreign body overall are peanuts. So children have a tendency to aspirate peanuts all around, all over the world they are available, and children, some peanut will be lying on the floor, the child will crawl or creep to that side, pick it up, and instead of swallowing may take it into the airway. That is the common presentation. What is the most common site of lodging of foreign? Where does the foreign body go and lie? It can lie in the upper airway, it can lie in the lower airway. In the lower airway, the lower airway lodging is more common than upper airway because upper airway will cause choking in the child. So any child presenting to you, the child had time to present, it would have lodged in the lower airway. In lower airway, it will go into the right bronchus. Why right bronchus? Whenever I take a live class, I always ask students why a foreign body goes into right bronchus, and they always give me the correct answer, because probably this is the only thing you remember from anatomy by the time you reach your final year, that right bronchus is wider, straighter, more in line with the main bronchus, and so objects have a tendency to go there. So right bronchus is the most common site of lodging of foreign body. However, very young children, infants, it may not always be true because the carina is more widely spread and the object can go either side. But overall, right bronchus is the most common site. What are the clinical manifestations, clinical features? Clinically, there is an acute manifestation. Acutely, there will be sudden onset of coughing, choking, vomiting, and respiratory distress, with or without cyanosis. There will be no fever in these patients. After that, either the symptoms may resolve only to present with complications later, or the patient may progress to severe airway obstruction. This is the usual presentation of foreign body aspiration. Foreign body aspiration, old MC cough is the most common symptom in these patients. When you do examination, you find that there is unilateral wheeze. On one side of the chest, you will find a wheezing sound to be present. When you perform a chest X-ray is usually normal because a radio-opaque foreign body is seen in only 10 to 25% cases according to Nelson. So most of them will not have any chest X-ray. You will not be able to identify the foreign body unless it is a radio-opaque object like a metallic thing or a small coin. However, if there is significant obstruction, chest X-ray features may be produced. In case of significant partial obstruction, the patient will have features of hyperinflation on chest X-ray. What is hyperinflation? One side of the chest, overexpanded chest. Because partial obstruction acts as a ball valve, it allows air to move inside during inspiration but traps outgoing air. So, unilateral hyperinflation will be present on the affected side. In case of significant obstruction which is complete on the affected side, there may be atelectasis or collapse on the affected side. What is the investigation of choice? Foreign body aspiration, it is rigid bronchoscopy. What is the treatment? The treatment is rigid bronchoscopic removal. It is both diagnostic and therapeutic. If the diagnosis is not clear and you are suspecting that it can be anything other than the foreign body, maybe some localized lymph nodes, maybe some tuberculosis or something, some rare condition, then for diagnostic purposes, flexible fiber optic bronchoscopy is better. But flexible fiber optic bronchoscope cannot remove the foreign body. Once you're sure or if there is a strong suspicion, you will go in for rigid bronchoscopic removal. At a lot of centers these days, they first do flexible fiber optic, then they go in for rigid bronchoscope, but it is just a matter of convenience. In a resource-limited setting like India, rigid bronchoscopic removal is the procedure of choice. It is both diagnostic as well as therapeutic. And a few one-liners we need to remember. You can remember that whenever there is foreign body in the upper airway, in case of infants, it can be removed by alternate blows to chest and back, and we do it 5 each. What it means is, you pick up the child, first 5 blows from on the back, then you turn the child 5 blows from the front, it dislodges the foreign body and makes the foreign body come out. And in case of older children and adults, you can try the Heimlich maneuver. In a young infant, Heimlich maneuver is not possible. In a Heimlich maneuver, you come from the back of the person, bring the arms like here on your epigastric region, and then you apply pressure backwards and upwards. So that is known as Heimlich maneuver. Heimlich maneuver is something which you have been taught in emergency medicine, ENT and a lot of areas. But in children, we don't usually perform Heimlich maneuver that common. In case of foreign body in lower airway, the only option we have is bronchoscopic. So these are the two things which can be asked as scenarios in your MCQ entrance exam. Before we go to the next topic, I want you to see an MCQ, a clinical example of an integrated MCQ which can be asked in entrance exam. It elaborates upon the presentation and the actual bronchoscopic investigation that we perform in the patient. Just have a look. So welcome back. Let us now move from foreign body aspiration to the next topic, that is acute bronchiolitis. Acute bronchiolitis. Acute bronchiolitis is an acute infection inflammation of the terminal and respiratory bronchioles. First of all, what is the age during which bronchiolitis happens? It occurs in the age group of 1 month to 2 years. It is virtually never seen beyond 2 years of age. Peak age is around 6 to 8 months. What are the risk factors? It is more common in male children. It is more common in children who are exposed to passive smoking. So children who have father or mother or uncles smoking at home, they have a higher risk. In fact, Nelson also says that studies have shown that mothers who smoke in pregnancy have their babies later on in life have a higher risk of developing bronchiolitis. So stay away from smoke, if not for yourself, at least for your kids. Don't pass on all this toxicity to your kid. It is toxic for you, it is toxic for everyone. So these are the risk factors, but acute bronchiolitis actually is a infective condition, and etiology wise it is a viral infection. Which is the most common virus? In almost 80% cases it is caused by a respiratory syncytial virus. Some of the Western textbooks give a value of 50% for RSV, whereas the Indian textbooks and the Southeast Asian and British publications give a value of 80 to 90%. Overall, RSV is the most common. So, most common is respiratory syncytial virus. It has been asked in NEET PG exam. Other common viral infections which can cause bronchiolitis, they include human metapneumovirus, influenza virus, parainfluenza virus, adenovirus, etc. They are the other common causes. Now, what is the clinical feature? What are the clinical manifestations? These children are found to have viral prodrome manifestations, which include low-grade fever, rhinorrhea, and cough. They will have mild to moderate respiratory distress, which can sometimes become severe as well as the disease progresses. They will have bilateral wheeze, and sometimes with or without crackles in the chest may be heard. It is considered to be a clinical diagnosis. It is mainly a clinical diagnosis. But when you perform chest X-ray, sometimes you may find some abnormalities. So what are the chest X-ray findings that you may find? Chest X-ray may be normal, or it may show bilateral hyperinflation if in case there is partial obstruction bilaterally. It may show hilar prominence, and it may show diffuse haziness of the lung fields. Where available, viral studies including PCR on nasal swab and bronchial washings can identify the offending agent. However, these viral studies are less available, and in fact in real life setting we seldom do it unless it is a super high tertiary care center and cost is not a factor and the child is really sick and you want to look at the possible reason. So what is the treatment of acute bronchiolitis? Treatment is very simple. Treatment is conservative management. We give high flow humidified oxygen therapy to most of these children. High flow humidified oxygen is a must if SpO2 falls less than 90%. 90% is the cutoff which is mentioned in American Academy of Pediatrics as well as New Nelson as the guidelines. So high flow humidified oxygen with or without, if the rates are very high, respiratory rate is very high, you will give IV fluids for some times, you will do fever control in case the patient is having fever, etc. So conservative management. There is no role of steroids, no role of antibiotics, no role of short-acting beta agonists, no role of Montelukast or tiotropium bromide, ipratropium bromide, etc. So it is a conservative management. Most of the children improve within 5 to 7 days. So there is spontaneous recovery occurring in most children in 5 to 7 days. However, the disease can have a fulminant course. It can have a severe fulminant course and high mortality in 3 risk groups. The three risk groups are immunosuppressed, child having HIV positivity or child on high dose steroid therapy. If the child is having a congenital heart disease like VSD, like PDA, like TOF, or if the child is having a chronic lung disease like cystic fibrosis. These high risk groups you need to consider a drug. And what is the drug of choice in such scenarios? The drug of choice is ribavirin. Normal patients, ribavirin is not used. It is a costly drug and it has side effects. So whether you give ribavirin or not, a normal child will come out of bronchiolitis in 5 to 7 days. So there is no rule. If question says what is the management of choice in bronchiolitis, nothing else mentioned. Answer will be conservative. If question says which drug to use, ribavirin. Where? Not in normal children who develop bronchiolitis, but if the child has any one out of these three risk factors. And finally, the question may ask you, is there any prophylactic drug? So prophylaxis of RSV can be done by a drug known as palivizumab. Palivizumab is a monoclonal antibody directed against F protein of RSV virus. In children who have these risk factors, there is a community outbreak or a season of bronchiolitis has come. Lot of cases are coming. To prevent the child from developing bronchiolitis, we give palivizumab injection. Palivizumab is a long-acting monoclonal antibody and protects the child only if there is a specific risk factor present. Normally, palivizumab is not indicated. Ribavirin as the drug, conservative management comprising oxygen and steam inhalation, and palivizumab is a prophylactic drug. All three have been asked already in entrance exam. So these are the points you must remember for future exams as well. Next, we come to the topic bronchial asthma in children. Now, bronchial asthma, as you know, it is a type 1 hypersensitivity condition in case of children. It is considered to be an allergic or atopic disorder. Most of these children are found to have a positive family history. What is bronchial asthma? It is a condition which is characterized by hyper-responsive airway with episodic bronchoconstriction. So there is a chronically inflamed, hyperallergic, hyperresponsive airway. Sometimes due to some allergen or due to unidentifiable causes, there may be episodic bronchoconstriction which responds dramatically to short-acting beta agonists like salbutamol. That condition is called as bronchial asthma. Classification-wise, in children, bronchial asthma can be divided into two types. You can have extrinsic bronchial asthma and you can have intrinsic bronchial asthma. The extrinsic disease is IgE mediated, that is, the immunoglobulin E levels will be high, and intrinsic is non-IgE mediated. Extrinsic disease, the acute attack is precipitated by allergen exposure. Whereas intrinsic disease, the bronchoconstriction, the acute attack is precipitated by infections in the body. It may be simply a viral infection. Practically speaking, it is very difficult to distinguish a child with extrinsic versus intrinsic, and overall management remains virtually the same. These are more of an academic thing which you need to remember rather than a practice thing. Moving to the clinical features, in these children, there can be two patterns which can be seen. Either the patient can have intermittent asthma clinically, or it can be persistent asthma. Intermittent asthma will have only occasional episodes, whereas persistent asthma will have episodes superimposed on other findings like cough, failure to thrive, and other atopic manifestations, which may or may not be there. Intermittent asthma is usually a mild asthma. Persistent asthma can be mild, moderate, and severe. And what are the features that you find? In each episode, there will be cough, there will be dyspnea, there will be wheezing in the patient. It is always a bilateral wheeze, and the symptoms are typically more in the early morning hours. This is the usual pattern of clinical manifestations in bronchial asthma. Now, earlier concept was asthma cannot occur in infants. That concept has been disregarded. It is just that presentation is atypical and it is difficult to diagnose. But asthma can occur across all age groups, although it may be impossible to diagnose it in very young children. So let us discuss briefly about diagnosis. Diagnosis part is controversial, difficult, and so we'll discuss it in some details because difficult questions on this are being asked in INI, CET and NEET PG exam. So the diagnosis of asthma says that there are many ways you can make diagnosis. Practically, in practice, as I see, as even OP Ghai accepts, the diagnosis is mostly clinical in case of children. How do we make the diagnosis? There should be at least 3 or more distinct clinical episodes, which I just described. 3 or more distinct clinical episodes of respiratory distress along with wheeze, which respond to, all these episodes should respond to bronchodilators, showing it is a reversible bronchoconstriction. Other than clinical, you can also perform spirometry, which can be possible only in case of older children. The traditional findings on spirometry include a low FEV1, low FEV1 over FVC ratio, which is usually traditionally the cutoff of less than 0.8 is taken for both adult and children. It has now been revised, as we will see later. These children are found to have a low peak expiratory flow rate, PEFR, which is often less than 80% of expected in severe cases. And you may also find low FEV 25 to 75, which is a marker, which is an indicator of air exhaled from alveoli and small bronchioles. Because it is an indicator of air exhaled from alveoli and small bronchioles, the low FEV 25 to 75 may not always be seen in patients with bronchial asthma, because bronchial asthma usually involves the larger airways as compared to the smaller airways. So, although you may find low FEV 25 to 75, it is not normally performed, and in fact, if you look at the latest GINA guidelines, FEV 25 to 75 is not included in one of the criteria for diagnosing the condition. Again, the interpretation, the definition of all these are taken from, extrapolated from adults, and so their utility in childhood is very limited. So the utility of these findings which we have done, it is mentioned in the textbooks, but it is very limited. Keeping this in mind, Global Initiative Against Asthma, the so-called GINA guidelines, came out with specific child-oriented spirometric criteria. And this is the hot thing for your MCQ entrance exam. The criteria says the spirometric findings suggestive of asthma diagnosis. It is a hot new thing. Question already asked in INI CET recently in the paper. So what are the spirometric findings that you are now supposed to remember? First, these children will be found to have low FEV1 by FVC. They do not give a cutoff. They simply say normal value in children is more than 90% of expected, that is more than 0.9. Any low value for the age, so there will be normograms for that. Any low value for the age will be one of the criteria for asthma. Second, if there is average daily diurnal variability in PEFR more than 13%. That is also taken to be one of the features. So you need to perform multiple readings and then take an average of that. Third, if on giving pre-bronchodilator you check, post-bronchodilator you check FEV1 and see the difference. If after giving bronchodilator, FEV1 increases by more than 12%, that indicates the positive responsiveness to bronchodilator. So again, it is one of the criteria. The fourth spirometric is positive exercise challenge test. What is positive exercise challenge test? After making the child exert, we check for FEV1 or PEFR. If there is FEV1 fall by more than 12% or fall in PEFR occurs by more than 15%, that is taken to be another criteria for asthma. The more criteria you are able to do, the better it is. Any of them, if it is positive, that indicates asthma in the child. It is a difficult thing, exactly remember it. Nobody will ask you how to perform it, but they have recently been asked in INI-CET Central Institute entrance exam, and they are likely to be asked even more details in the future exams. In general, OP Ghai says a very simple thing. It says any child, it is not a part of the GINA guidelines, but any child where there is peak expiratory flow rate less than 80%, there is variability in PEFR more than 20%, the patient is found to have clinically significant or severe asthma. But this severe asthma will always be responding to bronchodilators. So this is how you make the diagnosis of asthma in case of children. Now coming to the categories of asthma and the stepwise management. There is a small table you can remember. The more things you are able to put in this table, the better your category will be. There are 4 categories of asthma which are defined. 1 intermittent and 3 persistent. Intermittent is always mild. Persistent can be mild persistent, moderate persistent, severe persistent, right? Look at this. So we have 4 categories: intermittent, mild persistent, moderate persistent, severe persistent. Intermittent is said to be there where the daytime symptoms, the dyspnea, the shortness of breath, the wheezing, it is less than 1 per week, and nighttime symptoms are equal to or less than 2 per month. Peak expiratory flow rate is more than 80% of expected, variability is less than 20% of expected, right? Mild persistent will be there in case the frequency of daytime symptom is more than 1 per week but less than daily, and nighttime symptoms will be more than twice per month. Peak expiratory flow rate remains the same, but variability becomes 20 to 30%. Moderate persistent will have daily features, daytime symptoms. Nighttime symptoms will be more than once per week. Peak expiratory flow rate falls for the first time 60 to 80% and variability becomes more than 30%. And finally, we have severe persistent where all the time, daily, night, frequent symptoms will be happening. PEFR falls below 60% and peak expiratory flow rate is more than 30%. So this is the categories of asthma you are supposed to remember. You need to cram up. Entrance exams are all about having the right concepts and remembering the right things as well. So combine both of them together. How do we manage? So what we do is the stepwise management of asthma in children. Step 1. Step 1 is followed for intermittent asthma. Step 1 management comprises only short acting beta agonist. I am writing the short form here. I hope you know the full form. Short acting beta agonist. For example, salbutamol as needed. In short, it is written as SOS. That is as needed. Jab zarurat pade. Whenever there is acute attack, you will give it. No daily medication needs to be given. Right? Then you have step 2. Step 2 is given for mild persistent asthma. In mild persistent asthma, you will have to start a daily medication. You will use daily low dose inhaled corticosteroid, for example, budesonide. Plus you will use SABA, short acting beta agonist, SOS as needed. For any acute attack, additionally you will use SABA for a few days. Otherwise, daily low dose steroids have to be given inhaled route, not oral. Then we have step 3. If it is not controlled as step 2, you move to step 3, or if it is moderate persistent, you directly start with step 3. That is moderate persistent asthma. In moderate persistent asthma, you have 2 options here. Either you increase the dose of inhaled corticosteroid, you make it medium dose inhaled corticosteroid daily, or you continue low dose inhaled corticosteroid daily, plus you add either long acting beta agonist like salmeterol, or you can add montelukast, which is a oral medication available. SABA for any acute attack will continue SOS. And then we have step 4, which is used for severe persistent asthma. Severe persistent asthma, you need to use either high dose inhaled corticosteroid with LABA, that is long-acting beta agonist, or you can use 3 agents, medium dose inhaled corticosteroid daily, with LABA, with montelukast. And SABA will be used here also, SOS, whenever it is needed. So this is the management, stepwise management for each category of asthma as you define it. In step 4, sometimes short course of oral steroids may also be indicated, but that depends upon the clinical acumen and it is not a part of the standard guidelines. Now, according to the latest GINA guidelines, what are the second line or reserve drugs in severe asthma? Once all these routine medications have been used and the patient is not improving, what all you can do? The additional agents which you can try in severe asthma, they include, first of all, you can try inhaled tiotropium bromide or simply inhaled tiotropium in children equal to or more than 6 years of age. You can consider oral azithromycin, but not daily. You give in a dose of 5 to 10 milligram per kg body weight per day, 3 times a week for a few days, and then you see how the response happens. Azithromycin is a macrolide antibiotic which also has local anti-inflammatory action in the airways, and so it can be used as an add-on therapy, although the evidence for that is not very robust. So it is more of a reserve drug mentioned in the new GINA guidelines. Thirdly, you can consider biologicals in the patient. Biological refers to the biological agents, monoclonal antibodies. The biologicals approved for use in children include omalizumab. Omalizumab refers to anti-IgE monoclonal antibody, which has maximum evidence, useful in severe asthma as a second-line agent only in children at or above 6 years of age, not below this. You can try mepolizumab, which is anti-interleukin 5 in children equal to more than 12 years of age, and you can try dupilumab, which is anti-interleukin 4 receptor, again in children equal to or more than 12 years of age. So these are the second line agents which you can try. Additionally, sometimes questions ask you what agents can you give for prophylaxis in exercise-induced asthma in case of children. In exercise-induced asthma, you go in for, if there is an acute attack, you give short-acting beta agonist before exercise is going to be started. Otherwise, long-acting beta agonists can be given for a daily therapy. Alternative for that, long-acting beta agonist will be salmeterol. These days, formoterol is preferred because it is acute acting also and it is long-acting also. So it performs dual role. But long-acting beta agonists traditionally like salmeterol are given. Alternative agent for these children is oral montelukast. Now let us talk about the grading of acute asthma in case of children. In case of children, grading of acute asthma, any acute attack has happened. See, one was the diagnosis classification. Now is grading clinically of asthma, whether if an acute exacerbation has happened, it is mild, moderate or severe. So grading of acute asthma can be divided based upon a few features. So on one side you would write the features, then you would write 3 categories: mild, moderate and severe. First is color. Color is normal in mild asthma. It is normal in moderate asthma, moderate acute asthma attack. The child will be pale or cyanotic in case of severe asthmatic attack. Sensorium. It is normal. The child is anxious. Here the child is agitated. Then we look at dyspnea. Shortness of breath. It is absent, no dyspnea. Dyspnea is present. Dyspnea is severe. Then we ask the child to speak. In mild asthma, the child is able to speak sentences. In moderate, the child is able to speak in phrases. And in severe asthma, the child is able to speak in words or he is unable to speak. What it means? Let me clarify. We ask the child, we give him a sentence and we ask him without taking a break, you try to read it. Should not be a 10 sentence long thing, just a simple thing. So if the child is able to read, my name is Sham Kumar and I belong to Hazaribagh in Bihar. If he is able to read it without taking a pause, then it is mild asthma, right? If it is having a acute attack. If the child is able to speak like this, my name is Sham Kumar and I live in Hazaribagh, Bihar. He's speaking in meaningful phrases but taking pause in between. This is moderate asthma. Then, what is severe asthma? My name. He gets breathless after each word. That is severe asthma. He is unable to speak again. It is severe asthma. Then we look at the use of accessory muscles of respiration. Accessory muscles of respiration use, it is absent. No accessory muscles of respiration are being used. The child may have chest retractions here. In severe, there will be chest retractions, intercostal and subcostal, along with nasal flaring. Then we look at pulsus paradoxus. How to perform it, how to look for it is something you learn in clinics and in medicine. So pulsus paradoxus, here it is less than 10 millimeters, it is 10 to 20 millimeters and it is more than 20 millimeters in case of severe asthma. Peak expiratory flow rate, it is more than 80% in mild asthma, 60 to 80% in moderate and less than 60% in case of severe asthma. And SpO2, it is more than 95% on room air. It is 90 to 95% on room air. Here hypoxia is present, less than 90% on room air. So this is mild, moderate and severe asthma in case of children. Next we come to life-threatening asthma in case of children. What is life-threatening asthma? According to OP Ghai, any child with asthma having any one of the following is labeled as life-threatening asthma. So what are the things that you should remember? The child will, if the child is having central cyanosis, or if the child is having a silent chest, wheezing disappears is not a good sign, maybe the muscles are getting fatigued. If the child is having altered sensorium, if the child is having peak expiratory flow rate less than 30% of expected, if the SpO2 is less than 90% on room air, and if there is poor respiratory efforts, any of these is present, we say it is life-threatening asthma in child. How would you manage life-threatening asthma in children? First of all, start the patient on oxygen. Oxygen alone will not be effective, but you will start it. Along with that, you will start salbutamol nebulization. Then you will give injection epinephrine to the patient. If epinephrine is not available, you can give terbutaline to the patient. Doses will not be asked. It is not a theory paper. So epinephrine or terbutaline, they will be indicated. The doses basically depend upon the adult findings. The adult doses can be used in children as well. Dilute doses 0.1 ml per kg of 1:10,000 solution. But it varies according to the age groups. There are tables available for that. So we don't need to remember those doses at your pre-PG level. And you will give injection hydrocortisone. Hydrocortisone dose is important because it is specifically mentioned in OP Ghai. You need to remember that it is 5 mg per kg body weight. In case the patient improves, you continue nebulization plus shift the patient to oral steroids, that is prednisolone, and give for 3 to 5 days. In case there is no improvement or the patient worsens, you need to consider injection magnesium sulfate. Injection magnesium sulfate 50 mg per kg intravenously as a slow loading dose, or you can consider injection theophylline in the patient. And if that also fails, you shift the child to pediatric intensive care unit and consider intubation and ventilation. So this is the management of life-threatening asthma in case of children. Next, we come to appropriate inhalation devices for giving these medications in children. So, first of all, you may get a picture like this. What is this? This is known as a metered dose inhaler. Metered dose inhaler is a commonly used device which is used to deliver salbutamol or inhaled corticosteroids to the children. However, meter dose inhaler has a problem that you need to coordinate the inspiration with breathing pattern. So when you press it, along with breathing, coordination should happen, which is not possible in case of young children. So we use a modification of this in young children called as MDI with spacer. Spacer allows better drug concentration to give. So you have this MDI, this is the MDI inhaler, and this is the spacer device, which can be a cylindrical, sometimes it is like this as well. So a void kind of shape can also be there. So you attach it and it allows better rebreathing in the patient. Higher doses are given. So this is known as MDI with spacer. Third, you have this device. Very young children. In case the child is infant, and sometimes even children between 1 to 4 years, 1 to 3 years, you need to use this. So MDI plus spacer plus face mask is useful in these children. NEET PG MCQ old question. Child aged less than 1 year, you need to give some medication through inhalational route. Nebulizer is not available. What you will use? The best use will be MDI with spacer with mask. According to OP Ghai, MDI with spacer with mask is useful in children less than 4 years of age who require these medications. The fourth device is this. This is known as dry powder inhaler, DPI. DPI stands for dry powder inhaler. This does not require coordination, but it is useful only in older children. Dry powder inhaler, there are capsules of medicines available. As you can see in this picture, the capsule will be put here, then the capsule will be crushed and the child will breathe from this through the mouth and inspire deeply. The problem with dry powder inhaler, this particular device, there are many types of dry powder inhaler. This device is called as a rotahaler. This is a rotahaler, which is a type of dry powder inhaler device. The problem with these devices is that dry powder inhaler devices, they require good inspiratory volume. So very young children may not be able to use them properly. And finally, we have this device which does not require any breathing coordination. This is the nebulizer machine. So labeling of these and one-liners related to these can be asked as a visual. So this is the visual segment of asthma. Very important, not only for your practical exams, but also for NEET PG, Next PG and INI CVT exams.